Okay, we're going to talk about a minimally invasive Tailor's bunion correction, and we're going to go through some of the etiology and some of the ways we correct this through minimally invasive surgery. This is a pretty good procedure for minimally invasive surgery. In fact, it's a little easier than some of the traditional ways of doing this, and a good way to start minimally invasive surgery. So basically what is a Tailor's bunion is a prominent lateral condyle of the head of the fifth metatarsal. Usually it's accompanied by various deviation of the fifth toe, and this kind of depicts a patient with a fairly mild bunion, Tailor's bunion, and adductor varus fifth toe. Now we have three different anatomical variants here. We have patients that have an enlarged metatarsal head with a prominent lateral condyle. We also have patients that have an increased ion angle between the fourth and fifth metatarsal, with or without a bunion. That's going to be your most common Tailor's bunion you're going to see. And you also have patients that have an increased lateral curvature of the metatarsal. This is known as lateral deviation. This actually may not be a true measurement because when a patient has a very splayed foot, because of the angle of the convex nature of the metatarsal, when people stand and the foot splays out, the concave portion when you look up will make it appear bowed when in fact it's not bowed. So extrinsic factors such as improper foot wear, traumatic injury can add to and promote Tailor's bunion formation. So that's basically your etiology. The basic clinical manifestations, we all know this, is usually pain in the lateral aspect of the fifth metatarsal. The lesions can be on the lateral or the plantar or both, and may even lead to ulcerative areas. So these patients can become ulcerated and cause severe infections with our diabetic population. Now, radiographic studies are mandatory. In most literature, it's recommended that you have an AP and lateral weight bearing along with oblique. And the reason for these views is you have to measure the IM angle to pick the appropriate procedure. The IM angle is measured in a weight bearing AP view. Lateral deviation angle is normally not measured these days, although it can be measured. And also the status of the metatarsal phalangeal joint, whether it's congruent, subluxed, or dislocated, should be within your operative report or your findings. Now the medical treatments, we have to try these first. Appropriate footwear. Usually what you want to get is a straight last shoe. Pressure reducing orthotics to help eliminate pronation and take pressure off the area. Non-steroidal anti-inflammatory drugs for acute bursitis. Periodic foot care in our diabetic population. Ulcer care when they do have an ulcer. And injections for bursitis in the fifth MPJ. That would include both cortisone and serapin. Now our surgical options are kind of all over the place here. There's radical techniques, which would be the excision of the fifth metatarsal head. Now this is a very effective procedure, sometimes the most adequate procedure for a diabetic. However, the cosmetic outcome is usually very poor because it makes the toe retract back. And there's an exostectomy, which is basically reserved for a prominent fifth metatarsal with no structural IM abnormality. And then we have our osteotomies, and this is basically based on the IM angles. The normal IM angle between the fourth and the fifth is about 6 to 7. It's considered pathological when it's greater than 8 or 0.7 degrees. Now with the osteotomy, we have distal osteotomies, and this procedure is often performed together with the exostosis, and it would be the most common way this is performed. And then we have proximal and mid-shaft osteotomies, which are reserved for your larger IM angles and splay foot type patients. Most of the patients you will see will do well with a distal osteotomy. So this is how the procedure is performed. You do the procedure under the C-arm. You make an incision with a C-arm guidance with a 64 or 67 blade, looking at where you're going to make the actual cut into the bone. This is also performed under the C-arm. You can see the view here. Once that incision is made, you deepen this and create a channel for your rasp. With your rasp, and this is the channel you're going to be creating for your burr. You remove the soft tissue. You want to try to preserve the periosteum. At this point, you either do your exostectomy, which we show on the right side, or go ahead and do your osteotomy. Most of the time, like I said before, you're normally going to do your exostectomy and then your osteotomy. You'll remove the paste once the exostectomy is performed. Now it's time for your actual osteotomy. In this particular patient, we're doing this under C-arm. It's very vital. Also, we're angling this slightly distal to make sure the patient doesn't get a lot of shortening of the bone here. So this is an example here of an exostectomy, and which you can see where we perform that with the osteotomy as well. Then you transpose the osteotomy medially into a more radius position. It shows this right here. Now fixation can be done. It's optional. You can also just splint this over with a tight bandage, but fixation is also appropriate as well if you feel more comfortable with fixation. So once that's performed, you basically wrap it with a tight bandage splint, and fixation obviously is optional, as we stated before. So what is the post-operative care? The post-operative care is critical, and it's probably where you're going to have to really follow these rules to have a really good outcome. The forefoot is tightly bandaged or splinted with an Una boot and a stretch co-band, and that whether you fixate or not. Stockinette overlay and surgical shoe dispense is done. Immediate weight-bearing post-operative view is recommended. This is really a medical legal issue. After you do surgery and osteotomy, you should get an immediate weight-bearing AP X-ray with this particular procedure. Walking is allowed with the usual precautions. At day 7, the bandage and sutures are removed. If the patient is diabetic, the sutures are normally left in longer, possibly 2 weeks. You then have the patient do a co-band type self-adhesive elastic bandage is applied. The patient can do this themselves. You teach them how to do this. You want to repeat a weight-bearing dorsal plantar and lateral x-ray to confirm that you have proper position of the osteotomy. Patient will be instructed how to change the bandage every day after bathing. This bandage is worn 3 weeks. Walking is limited only to the post-operative shoe. At week 4, the patient is examined with the x-ray. This is 1 month later to confirm that you are getting fibrous callus consolidation. The bandages then can be removed at night but need to be kept on during the day. And the patient will continue to wear the post-operative shoe for another additional 2 more weeks. At 6 weeks, you gradually switching into a wide shoe with a rigid sole and laces. Follow-up x-rays are required 1 month after the surgery and 3 months to confirm definitive bone consolidation. Here is the MIS procedure, and we're just going to talk it out as we do the procedure. Make an incision on the lateral aspect overlying the proximal portion of the Tailor's bunion. You can see here, this is performed under the C-arm. If you notice, I have protective gloves on, and this is to protect from radiation. Next, once the incision is made, the soft tissue is then underscored with a small rasp. This is to create a channel for your rasp, as well to remove soft tissue so it's not injured with the burr. Normally, I free both the plantar and lateral and dorsal aspects of the soft tissue, so you have a free movement with the burr both on the plantar and dorsal surfaces here. Once you know you have good path for your burr, the burr is then inserted. At this point, in some patients, you go ahead and do the exostectomy. On this patient, we're just doing this patient has a plantar lesion ulcer, so we're just basically elevating the metatarsal here and shifting over just a slight bit. Now we use either a short Eischen burr. In this case, this guy has a little bit bigger bone, so we're going to do a regular Eischen burr, or a Shannon will work as well. A wedge osteotomy is then performed. This is also done under the guidance of C-arm, so you know exactly where you are. So you know you're not too far in the inner space, but know exactly where your position's at. We'll cut this slightly in a little bit of position where you maintain some link to the metatarsal. So when you make your cut, you're basically pushing downward here, but you're also doing reciprocating movements back and forth, and that's to keep the burr not from heating up and for making a good clean path. You don't want to burn the bone. If you get bogged down, take that out and use another burr, or cool this, let it cool. So the thing is not to get thermal necrosis, because that will delay your bone healing. Now even while performing the osteotomy, you can definitely gauge what you're doing with the C-arm so that you're getting a appropriate cut here. Once again, notice that the gloves are radio protected gloves. So you make sure you're keeping the stain plane here. It's a little different feel than a saw, but it does cut pretty quick. It cuts in about 30 to 40 seconds or so. Once that's cut, you assess your cut on the C-arm by distracting the toe, which we'll do right now. You can see that when we distract the toe, you can see our cut in the bone there. That's then pushed over medial, and then either fixated or a tight splint bandage is performed. This is the process of pushing the bone up, in this case, and over medially. And checking to make sure you're through the cut, and you can actually palpate and feel that. So, let's look at a percutaneous case. This is case 1. This is a patient with a elevated IM angle, and she has like a congruent first met, but it's a little deviated medially, fifth met. So we want to correct that fifth met and line that up too. So with this patient, we did an osteotomy, made a little wedge on the medial side so we could correct our adductor varus of the toe. This patient was very concerned about cosmetic outcomes. She's a young girl, about 18 years old. So this is the result we got here. You can see the pre-op there, post-op there. When she looks down at her foot, she doesn't see a scar, is what she kind of wanted. Now, when you talk about X-ray interpretation, when you do fixate, you will get quicker consolidation. This does not necessarily correlate with subjective outcome. So X may not equal Y is what we say here. For example, here's case 2. This is a 50-year-old male with a plantar lateral fifth met pain and previously failed correction of adductor varus fifth toe by another surgeon through arthroplasty. This is a 12-week post-op X-ray. His MIS Tailors, it was non-fixated. Patient is completely pain-free, never took pain meds for the surgery, despite less than ideal X-ray results. This will actually go in and consolidate or just form a fibrous union here that will never be an issue for the patient. Case 3, this is a 50-year-old female with plantar lateral fifth met pain, the same as the other person. This is also a 12-week post-op. MIS Tailors, the osteotomy was fixated with a K-wire. So this patient is completely pain-free as well. However, she required 2 rounds of pain medicines post-surgery despite ideal X-ray results. So you see good consolidation there. The X-ray, kind of in 12 weeks really looks good after 12 weeks because we did fixate this with a K-wire. So to be fair with the K-wire, this is a patient that we did a particularly extensive 4-foot reconstruction on, including a revered nichum, an Aiken, tried to get some toe, transverse toe correction done with toes 2. With toes 2, 3, 4, and 5. So this patient was completely pain-free and never took pain medications despite extensive 4-foot surgery here. So in conclusion, MIS lends itself well to Tailor's bunion correction. It's a good procedure performed as your first MIS case. Not a lot of stuff to injure here. Not any major nerves. Your sural nerve is behind this area when you're doing a distal osteotomy. So it's a very good case to cut your teeth on with MIS surgery.